Last month, a 68-year-old man named Gerald came into my office and sat down across from me with the kind of calm that only comes from someone who genuinely believes nothing is seriously wrong. He told me his ankles were a little puffy by evening. He told me he was tired, but then again he said who his age was not tired. He mentioned that his skin had been itching for months, but it was winter, and the air was dry, and he had switched laundry detergents, and there were a dozen perfectly reasonable explanations sitting right there for the taking. Gerald had been explaining things away for 3 years. What his blood work showed was that his kidneys had already lost more than 60% of their functional capacity. 60%. Gone, silently, without a single moment of dramatic pain, without a single alarm that he recognized as an alarm, without anything that felt like a medical emergency, because none of it did. All of it felt like getting older. That is the defining characteristic of kidney disease in its early and middle stages. It does not announce itself. It does not send pain. It does not produce symptoms that feel urgent or frightening. It produces symptoms that feel entirely consistent with being the age you are, symptoms that are easy to rationalize, easy to attribute, easy to set aside for another day. By the time 10% of people with early kidney disease know they have it, the other 90% are still explaining their symptoms away, still blaming the weather, still blaming the laundry detergent, still planning to mention it at their next annual physical, which is scheduled for 6 months from now. Your kidneys filter approximately 200 liters of blood every single day. They regulate your blood pressure, your fluid balance, your electrolyte levels, your red blood cell production, and the acid-base chemistry of every cell in your body. They are among the most essential organs you possess, and they give almost no warning, until the damage is already substantial. Today we are going through 7 specific signals that the body produces when the kidneys are struggling. Signals that are documented, clinically recognized, and consistently misattributed to aging until it is too late to change the trajectory of what comes next. This is what your body may have been trying to tell you for years. The first sign is something most people see almost every morning and have never been told to take seriously: foam in the urine. Not a few bubbles that disappear within seconds, not the brief turbulence of a fast stream hitting water. Foam that is thick, persistent, and stable. Foam that is still present after you have flushed. Foam that looks, in Gerald's own words, like the head on a glass of beer. Inside each kidney, you have approximately 1 million microscopic filtration units called nephrons. Each nephron contains a tiny cluster of blood vessels, a glomerulus wrapped in a capsule, connected to a tubule through which filtered fluid flows before becoming urine. The glomerulus functions as an extraordinarily precise molecular sieve. Its job is to allow waste products and excess fluid to pass through into the urine while retaining valuable substances, including proteins, in the bloodstream. Chief among the proteins that healthy kidneys retain is albumin. Albumin is the most abundant protein in human blood. It maintains the osmotic pressure that keeps fluid inside the blood vessels rather than leaking into surrounding tissue. Healthy kidneys keep albumin precisely where it belongs in the blood, and virtually none of it appears in the urine. When the glomerular filtration membrane is damaged by years of elevated blood pressure, by chronically high blood glucose, by inflammation, its ability to retain albumin breaks down. Albumin begins leaking through the damaged membrane into the urine, and albumin in urine behaves exactly like soap. It lowers the surface tension of the water it contacts, it creates stable bubbles, it produces foam that does not collapse and does not clear because the protein that is generating it continues to pour through the damaged filter with every heartbeat. The medical term for this is proteinuria, and proteinuria is not simply a symptom of kidney damage, it is also an accelerant of that damage. The albumin that accumulates in the tubules of the kidney triggers a local inflammatory response. That inflammation produces scarring. That scarring destroys more nephron tissue, which allows more protein to leak, which triggers more inflammation, which produces more scarring. A self-perpetuating cycle of destruction visible every morning in the foam that forms in the toilet bowl and dismissed every morning as nothing worth mentioning. If foam is consistently present in your urine, foam that is stable, that does not dissipate quickly, that appears most or all of the time, that single observation is sufficient clinical justification for a urine test called a UCR, a urine albumin to creatinine ratio. It is a simple, inexpensive test. It can be ordered at any routine appointment, and it can detect kidney protein leakage years before any other test shows an abnormality. The second sign is visible on your legs every evening when you remove your socks. The indentation left by elastic, the mark that socks leave around the ankle, normally fades within minutes as the compressed tissue springs back. in swelling caused by fluid accumulation in the tissue, a condition called pitting edema that indentation does not spring back. Press your thumb firmly against the inner ankle or the top of the foot and hold it for 5 seconds. Release. If the indentation remains a visible pit in the tissue that slowly fills back in over 10 to 30 seconds, that is pitting edema. The mechanism connecting pitting edema to kidney dysfunction is the same albumin story, extended downstream. When albumin leaks from the blood into the urine, blood albumin levels fall. As blood albumin falls, the osmotic pressure that normally holds fluid inside the blood vessels decreases. Fluid escapes from the capillaries into the surrounding tissue. Gravity pulls that fluid downward to the ankles, to the feet, to the lower legs. The result is swelling that worsens throughout the day as the person remains upright, and that may partially resolve overnight when the legs are elevated. Simultaneously, damaged kidneys lose their ability to excrete sodium efficiently. Sodium retains water wherever it accumulates. Fluid that the kidneys cannot eliminate redistributes into tissue throughout the body, compounding the edema produced by the protein loss. This combination of protein-driven and sodium-driven fluid accumulation in the lower extremities is one of the most recognizable early external signs of kidney dysfunction and one of the most consistently attributed to something else. Heavy legs from standing all day, varicose veins, poor circulation, heart problems, joint problems. The list of explanations that patients and sometimes physicians reach for before considering the kidneys is long, and the kidneys are frequently the last possibility considered, despite the fact that a simple blood test measuring kidney function can definitively determine whether they are contributing to the edema within a single clinic visit. The third sign appears in the mirror every morning and is almost always attributed to poor sleep. Swelling of the tissue around the eyes, puffy, heavy eyelids, a fullness in the face upon waking that was not present when you went to bed. The skin around the eyes is among the thinnest and most elastic in the entire body, approximately 0.5 millimeter thick in some areas. It contains very little supportive connective tissue, and it is directly adjacent to a rich vascular network of small blood vessels and lymphatic channels. When systemic fluid regulation is disrupted, as it is in early kidney disease, the periorbital tissue surrounding the eyes is frequently the first area where excess fluid becomes visibly apparent. During the hours of sleep, when the body is horizontal and the effect of gravity on fluid distribution is removed, fluid that would otherwise pool in the ankles and lower extremities redistributes throughout the body. In someone with compromised fluid regulation, that redistribution includes the tissue around the eyes. The clinical characteristic that distinguishes kidney-related periorbital edema from the normal puffiness of insufficient sleep is its timing and its pattern. Kidney-related periorbital swelling is typically most pronounced immediately upon waking and gradually decreases and shifts downward as the person spends time upright during the day. Sleep-related puffiness resolves quickly, usually within 30 to 60 minutes of rising. When persistent morning periorbital swelling is present alongside foam in the urine, the combination represents a highly specific clinical pattern that points directly to a problem with the kidney's ability to manage protein and fluid balance. The fourth sign disrupts sleep and is almost universally attributed to the bladder, the prostate, or simply the realities of aging past 60, waking multiple times each night to urinate, a condition called nocturia. One nighttime trip to the bathroom in a person over 50 is within the range of normal. 2, 3, or 4 trips per night consistently, not occasionally, represents a change from the normal pattern of kidney behavior that deserves clinical attention. The kidneys, under healthy conditions, respond to a hormonal signal during sleep. The pituitary gland releases antidiuretic hormone, also called AD or vasopressin, which instructs the kidneys to concentrate the urine during the night hours, reducing urine volume so that sleep can continue uninterrupted. The tubular cells of the nephron respond to this signal by reabsorbing water back into the bloodstream, producing a smaller volume of more concentrated urine. When the tubular cells of the nephron are damaged by chronic kidney disease, by years of elevated blood pressure, by diabetes, they lose their ability to respond to antidiuretic hormone. The kidney continues producing urine at a rate that more closely resembles its daytime output, dilute, high-volume urine that accumulates in the bladder repeatedly throughout the night. The result is a person who wakes every 2 hours, who attributes it to an aging bladder or an enlarged prostate, who has never been told that the tubular cells of the kidney have a role in determining how often they rise in the night, and the consequence extends beyond interrupted sleep. The chronic sleep deprivation produced by nocturia elevates cortisol levels, raises blood pressure, impairs glucose metabolism, and reduces the body's ability to repair tissue, directly worsening the conditions that are damaging the kidneys in the first place. The fifth sign is one that surprises patients consistently because it feels like a skin problem, not a kidney problem. A deep, pervasive itch, not localized to one area, not associated with a visible rash or an identifiable skin irritant. A systemic sensation of itching often described as feeling as though it is coming from beneath the skin rather than from the surface, that is frequently worse at night, that does not respond to moisturizing creams, and that does not improve with antihistamines. The medical term is uremic pruritus, and the mechanism is entirely internal. When kidney filtration capacity falls below a critical threshold, waste products and minerals that should be cleared from the bloodstream begin to accumulate. Among these is phosphorus, a mineral that the kidneys are responsible for excreting in regulated amounts. As phosphorus accumulates in the blood beyond normal levels, it deposits in peripheral tissues throughout the body, including in the dermis, the layer of skin beneath the surface. These phosphorus deposits and the broader accumulation of uremic toxins in the blood trigger an immune response in the skin. Immune cells react to the deposited material as though it were a foreign substance, releasing inflammatory mediators that produce the sensation of itch through stimulation of cutaneous nerve endings. Unlike itch produced by dry skin or by contact with an irritant, uremic pruritus does not respond to the interventions designed for those causes. Moisturizer does not reach a phosphorus deposit in the dermis. Antihistamines do not block the specific inflammatory pathway that uremic toxins activate in the skin. A person with uremic pruritus who moisturizes faithfully, who changes their soap and their laundry detergent, who takes antihistamines at night and still cannot stop scratching is not dealing with a skin problem. They are dealing with a filtration problem, and a blood test measuring serum phosphorus levels can confirm or exclude this explanation within hours. The sixth sign involves taste and smell and is among the most specific and clinically significant on this list. A persistent metallic taste in the mouth. A taste described variously as copper, as pennies, as bitterness that coats the tongue regardless of what has been eaten or drunk. Breath that has taken on a faint but unmistakable odor of ammonia, sometimes described as resembling urine, or as a chemical sharpness that was not previously present. Accompanying these oral changes frequently is a progressive loss of appetite, a diminished interest in food, a specific aversion to protein-rich foods, meat, eggs, fish that previously had no negative association, an inability to enjoy meals that was not present months ago. The mechanism is direct. When kidney filtration fails to adequately clear the bloodstream, the nitrogenous waste product urea accumulates in the blood. Urea, which in health is produced continuously by the liver from the breakdown of amino acids and transported to the kidneys for excretion in the urine, reaches concentrations in the bloodstream that allow it to diffuse into saliva. Bacteria present naturally in the oral cavity metabolize urea into ammonia. Ammonia produces a sharp, metallic, chemically distinct taste and odor. The condition systemic accumulation of urea and other nitrogenous waste products in the blood is called uremia, and its manifestation in the mouth is one of the most direct signals the body can produce that the kidneys are no longer adequately clearing the internal chemical environment. The aversion to protein-rich foods that frequently accompanies this change appears to be a partial protective response. As protein metabolism generates the urea that the failing kidneys cannot clear, the body's sensory system begins to associate protein consumption with the discomfort of uremia. Patients eat less, their nutrition deteriorates, their energy declines, and they attribute the entire progression to aging, to reduced appetite, to simply not being as hungry as they once were. The seventh sign is felt in the back and is almost always attributed to the most convenient available explanation, a deep, constant bilateral ache located just below the rib cage on either side of the spine in the area anatomists call the flank, an ache that does not change when position changes, that does not worsen with specific movements the way a muscle strain does, that does not improve with stretching, with rest, with heat application, or with the passage of days. The kidneys are located in the retroperitoneal space behind the abdominal cavity, tucked against the posterior wall of the trunk, just below the 12th rib on each side. They are wrapped in a fibrous capsule, a tight, inelastic covering studded with pain receptors. Any process that causes the kidney to swell, inflammation, obstruction, infection, or the internal pressure changes associated with compromised filtration stretches this capsule and produces pain. The pain is deep because its source is deep. It is constant because the pressure generating it is constant. It does not change with position because the kidney is not a musculoskeletal structure moving the spine, or the surrounding muscles does not alter the pressure inside the organ. The flank ache of kidney origin is clinically distinguished from musculoskeletal back pain by its constancy, its location, its independence from movement, and its association with other kidney-related symptoms. A muscle strain hurts more with certain movements and less with others. A kidney under pressure hurts the same regardless. When a persistent, deep position-independent ache in the flank area is accompanied by any combination of the signs already described: foam in the urine, ankle swelling, morning periorbital edema, nocturia, uremic itch, or metallic taste, the pattern is not ambiguous. It points to a single organ system that is struggling to perform the function it has performed every hour of every day of your entire life. Now let us bring this together with complete clarity. 1 in 10 adults globally has some degree of chronic kidney disease. In the United States, the prevalence among adults over 60 is significantly higher, driven by the prevalence of hypertension and diabetes in that population, two conditions that are among the most potent drivers of kidney damage known to medicine. And of those with early chronic kidney disease, approximately 90% do not know they have it, not because the signs are absent, but because the signs feel like aging: foam in the morning, urine dismissed as nothing, sock marks on the ankles attributed to a long day on the feet, puffy eyes blamed on a restless night, 3 trips to the bathroom before dawn explained away by an aging bladder, skin that itches relentlessly through winter attributed to dry air, a metallic taste in the mouth treated with mints and attributed to dental issues, a constant ache below the ribs blamed on last weekend's gardening. 7 signals, all present in the same person, all dismissed individually, all pointing collectively to an organ that has already lost more than half of its functional capacity. Gerald's treatment has begun. What remains of his kidney function is being protected, but what was lost in the 3 years of explaining away cannot be recovered. The kidney, unlike some organs, does not regenerate. Nephrons destroyed by years of unaddressed damage do not grow back. The goal of early detection is not recovery, it is preservation, catching the damage while enough function remains to be protected. A blood test called the GFR glomerular filtration rate measures how efficiently the kidneys are filtering the blood. A urine test called the urine albumin to creatinine ratio measures how much protein the kidneys are leaking. Together, these 2 tests provide a complete picture of kidney function that no symptom assessment alone can provide. They are inexpensive, they are available at any standard laboratory, they can be ordered at any routine medical appointment. And they can tell you something about the health of your kidneys that your body, in its quiet, persistent, easily rationalized way, has been trying to tell you for years. 7 signs, 1 organ, 1 window that remains open only as long as there is still function left to protect: foam in the urine that persists and does not clear, pitting edema in the ankles and lower legs that worsens through the day, periorbital swelling that is worst upon waking and shifts downward as the day progresses, nocturia, waking 2 or more times per night consistently to urinate, deep, systemic, position-independent itch that does not respond to topical treatments, metallic taste and ammonia breath accompanied by progressive appetite loss, constant flank ache that does not change with movement or position. None of these signs alone confirms kidney disease. Every one of them has benign explanations that are far more common than kidney failure. But the pattern 2, 3, 4 of these signs in the same person, particularly in the presence of high blood pressure or diabetes, is not coincidence. It is a biological argument that deserves a clinical response, not another season of rational explanations. If this information reached you at the right moment, share it with someone it might reach even earlier. Subscribe for more evidence-based health information, clearly and honestly explained. Stay informed, stay aware. We will see you in the next one.